Hi, my name is Carrie Beasley, and I'm a fourth-year medical student at Brody School of Medicine at East Carolina University. I am on my OBGYN perinatal active internship at ECU Health. Today, I'm going to give a presentation on a risky business, comparing risk factors between PPROM, PTL, and PRE-E. When I was on my third-year clerkship, I always got confused between all the pathologies that started with P. So today, we are going to go over them and the risk factors that lead to them. Our learning objectives for this video include to compare the risk factors between preterm premature rupture of membranes, PPROM, preterm labor, PTL, and preeclampsia, PRE-E. We are also going to compare the management and treatment between PPROM, PTL, and PRE-E. And just like Tom Cruise, we are going to cruise through this information. First up, the risk factors. PPROM, PTL, and PRE-E. Just like every OBGYN pathology, having a history of that pathology leads to an increased risk of developing that pathology in the future. So, PPROM in a prior pregnancy, PTL in a prior pregnancy, PRE-E in a prior pregnancy leads to an increased risk of that in the next pregnancy. Also, multiple gestation for all three of these pathologies is an increased risk for having that pathology again. For PPROM and PTL, short cervical length, less than 25 millimeters, vaginal bleeding, and low maternal BMI can increase the risk of PPROM and PTL. In contrast, high maternal BMI can increase the risk of PRE-E. For PPROM, preterm labor in a prior pregnancy can increase the risk. Ascending infections, like sexually transmitted infections, smoking, polyhydramnios, and low socioeconomic status can all increase the risk of PPROM. Polyhydramnios is designated on ultrasound. We look at the maximum vertical pocket, MVP, and amniotic fluid index, AFI. If the MVP is greater than 8 or the AFI is greater than 25, that constitutes a diagnosis of polyhydramnios. For PTL, cervical surgery and short interval pregnancy increases the risk of preterm labor. For PRE-E, having PRE-E in a first-degree relative, primiparity, and new paternity, meaning a new baby daddy, can increase the risk of PRE-E. Also, a multitude of maternal factors, maternal hypertension, maternal renal disease, hypercoagulability, diabetes, obesity, lupus, all the autoimmune diseases, an age greater than 40 years can increase the risk of PRE-E. All those maternal factors sounds like the patients of Eastern North Carolina. And that's it for risk factors. Next up is treatment. We're going to organize the treatments for each of these pathologies by gestational age. Recall that gestational age less than 37 weeks is considered preterm, and preterm babies have their own risks. They're at increased risk for respiratory distress syndrome, intracranial hemorrhage, necrotizing enterocolitis, and even death. That's why it's so important to know about PPROM, PTL, and PRE-E, especially when the delivery is before 37 weeks. First, we're going to look at PPROM. For PPROM, if rupture of membranes occurs after 37 weeks, these moms, 90% of them, undergo spontaneous labor. If rupture of membranes occurs between 34 and 37 weeks, moms will likely undergo induction of labor, hopefully leading to a vaginal delivery. Induction of labor can also occur with cervical ripening agents, including Cytotec, aka misoprostol, or Pitocin, aka oxytocin. Induction of labor decreases the risk of chorioamnionitis, endometritis, and admission to the NICU. All good things. But remember, vaginal delivery isn't our only route of delivery. We may also have to proceed by C-section. So route of delivery is decided by fetal presentation, cervical status, fetal gestational age, and overall maternal fetal condition. PPROM between 24 and 34 weeks has the mainstay treatments of corticosteroids, latency antibiotics, inpatient management, aka living in the hospital, and delivery at 34 weeks. These moms also receive magnesium sulfate less than 32 weeks. Magnesium sulfate decreases the risk of cerebral palsy and offers neuroprotection to baby. The corticosteroids that moms receive allows baby to have lung development. The corticosteroid regimen includes betamethasone, two 12 milligram doses given IM 24 hours apart over 48 hours, or dexamethasone, 4 6 milligram doses every 12 hours administered IM. Most likely you'll see betamethasone, and you'll see in the chart or in the unit a mom being beta complete, meaning she has received her doses of betamethasone. Moms may also receive a rescue dose or rescue corticosteroids, and this is considered in women at the risk of delivery in 7 days, and it's been at least 2 weeks since they've completed their antenatal course of corticosteroids. The latency antibiotics that PPROMers receive include 7 days of 2 antibiotics: ampicillin 2 grams IV Q6 hours for 48 hours, then amoxicillin 250 milligrams TID for 5 days. And the whole time throughout these 7 days, this mom is also receiving erythromycin 250 milligrams PO Q6 hours. And remember, delivery is at 34 weeks, but if mom develops an infection, especially chorioamnionitis, that mom is going to deliver sooner than 34 weeks. So maybe even 30 weeks or sooner than that. Signs of chorioamnionitis include uterine funnel tenderness, maternal tachycardia, fetal tachycardia, purulent cervical discharge, and maternal leukocytosis. Treatment for chorio includes ampicillin and gentamicin, but for a penicillin allergy, cefalozolin and gentamicin can also be effective. Also for PPROM, less than 24 weeks is considered pre-viable PPROM. Pre-viable risks include pulmonary hypoplasia, oligohydramnios, fetal deformations, and limb contractures. Think of the Potter sequence with oligohydramnios. Some moms with pre-viable PPROM are admitted to the hospital before 24 weeks, waited out all the way to 34 weeks, and still deliver a baby with pulmonary hypoplasia. Next up is preterm labor. Preterm labor, they also receive corticosteroids for lung development, and they also get short-term tocolytic therapy. This is a short-term treatment for 48 hours to hopefully halt labor. They also receive magnesium sulfate less than 32 weeks to decrease the risk of cerebral palsy to offer neuroprotection. The short-term tocolytic therapies to decrease labor includes calcium channel blockers, NSAIDs, beta-adrenergic receptor agonists, and magnesium sulfate also. But we have to be careful with NSAIDs. They're safe in the second trimester, but they're risky in the first trimester because they can cause maternal renal dysfunction, and also they're risky in the third trimester because they can cause fetal PDA closure. Now, there's a certain patient population that is contraindicated to give magnesium sulfate, which acts as, neuroprotection and tocolytics for preterm labor. Can you think of this patient population? They have a antibody against the postsynaptic acetylcholine nicotinic receptor. Do you know what I'm talking about? If you're thinking myasthenia gravis, you are correct. These mothers cannot receive magnesium sulfate. Even Tom Cruise is happy that you got the question correct. Last but not least is PRE-E. PRE-E requires close surveillance, ultrasound for fetal growth every 4 weeks, and blood pressure control with hydralazine, labetalol, or nifedipine. These moms receive frequent blood pressure monitoring, serum, and urine evaluation. Prophylaxis with aspirin is also initiated between 12 and 28 weeks, optimally before 16 weeks, and is continued until delivery. These moms also receive magnesium sulfate less than 32 weeks. However, magnesium sulfate is also used for a second purpose for preeclampsia. It's also used for seizure prophylaxis during labor. The therapeutic level for magnesium sulfate is 4.8 to 8.4, a palindrome, if you will. We also assess for magnesium toxicity. The first signs of toxicity include lethargy, decreased deep tendon reflexes, and respiratory depression. You'll see us on the unit doing mag checks every 4 hours for patients on magnesium to make sure they have not developed toxicity, and sometimes we'll have to get a magnesium level to make sure of it. Preeclampsia moms also receive corticosteroids. They also receive twice weekly umbilical Dopplers and NSTs. Now, delivery for preeclampsia is tricky. We try to deliver at 37 weeks. However, if a mom with preeclampsia develops severe features, delivery is at 34 weeks. Severe features include thrombocytopenia with a platelet count less than 100, elevated liver enzymes twice the upper limit of normal, severe persistent right upper quadrant epigastric pain not accounted by another diagnosis, renal insufficiency or creatinine greater than 1.1 or double their normal creatinine if they have a renal disease, pulmonary edema, new onset headache unrelieved by Tylenol, and visual disturbances. Now, there are 3 stars on the slide, meaning if a mom develops any of the blue box symptoms, they're delivered regardless of gestational age. So if a mom has developed seizures and eclampsia, HELP syndrome, oliguria, pulmonary edema, non-reassuring fetal status, or persistent neurological symptoms, we deliver regardless of gestational age. And delivery route is determined by the factors mentioned before, can be vaginal, can be C-section. And HELP syndrome is something we assess for in many of our preeclampsia patients. We often order HELP labs, including a CBC to assess platelets, a CMP to assess liver enzymes, creatinine and bilirubin, and an LDH. So here is our summary treatment slide. You can see for PPROM, PTL, and PRE-E, all moms get magnesium sulfate for neuroprotection. All moms get corticosteroids for baby's lung development. PPROMers get latency antibiotics. PTL gets short-term tocolytic therapy in the hopes that they don't actually go into labor and can finish out their gestation. And then PRE-E, we have to make sure their blood pressure stays under control, and we give them blood pressure medications. And last but not least, here is our risky business summary table with our similar risk factors between pathologies, our different risk factors between the pathologies, and a summary of the management and treatment for each of the 3. I hope that you enjoyed this video and it made it a little bit more clear. Enjoy the rest of your OBGYN clerkship.